Hi, my name is Chris Wilson, and I'm a PGY1 pharmacy resident at Erlanger Health System in Chattanooga, Tennessee. And today I'm going to talk about my research project, which focused on evaluating status epilepticus treatment at our hospital. My preceptors and I do not have anything to disclose at this time, and my presentation objective is to describe trends in status epilepticus treatment and changes in practice resulting from implementation of a status epilepticus order set. Background going into treatment of status epilepticus: all patients should be receiving at least emergent and urgent therapies upon presentation, and I've listed these therapies below. The most common urgent therapies are fosphenytoin, valproate, and levetiracetam. Patients that are refractory to these therapies can be placed on a continuous infusion for refractory status epilepticus, and I've listed these therapies as well. When it comes to initial management of status epilepticus, underdosing of benzodiazepines is very common. The common dose that I see is lorazepam 2 milligrams, which is 50% of what's recommended in the guidelines. There's also a lack of evidence to suggest a preferred urgent therapy for patients, and there's also inconsistencies with dosing recommendations between guidelines and what's listed in the primary literature. Suboptimal monitoring can increase risk of adverse events given the high risk of these medications. So getting anti-epileptic drug levels, labs, EKGs, and vital signs, and of course continuous EEG monitoring for patients on continuous infusions is vital for mitigating these risks. Erlanger is a level 1 trauma center as well as a tertiary referral center. So we see a lot of acute patients that come into our emergency department, but we also have a fair amount of patients that come in to our hospital from outside hospitals. The purpose of my project was to improve evidence-based treatment of status epilepticus through the development of a standardized protocol in collaboration with the neurology physician group at Erlanger. Our primary objective was to compare AED usage, including place in therapy and dosage, both before and after implementation of our order set. Our secondary outcomes focused on monitoring, length of stay, intubation rates, and adverse events. Patients were identified via status epilepticus diagnosis code, and I've listed the dates of the pre-protocol and post-protocol data collection. You'll note that in the post-protocol group, we are still collecting data on patients, and the date of December 19th was chosen because that was the date that our status epilepticus order set was implemented. We've also spent the early part of this year providing education to multiple provider groups that we identified as being high users of this order set. I list this just for your reference, but this is the criteria we used to determine whether or not a dose was appropriate for our study. We included all patients diagnosed with status epilepticus, and I've listed the exclusion criteria that are pertinent for our study. As far as demographics, there are currently no statistical differences between the pre-protocol and post-protocol group. You'll note that in the post-protocol group, we have significantly less patients. However, this is due to our continual accrual of patients through our continuous data collection. We do have a large number of patients that come in with a history of seizures, meaning that they're presenting with breakthrough seizures. We also have a large number of patients that come into our emergency department. However, we do have a fair amount of patients that come from outside hospitals, as I mentioned. I wanted to mention our etiology due specifically to the other and unknown category. We have a large number of patients in this category because of the retrospective nature of the study, and that's one of the limitations of our study. For our primary outcome, we do have a statistical difference in appropriate therapy selections overall. We also see a trend in increase in our appropriate dose selection. However, this is currently not statistically significant. Looking more at a subgroup analysis of the first 3 therapies that patients receive, you see across the board that patients are receiving more appropriate therapy selections. There's also a statistical difference in the appropriate dosing selection in the graph on the right. For both emergent therapies, which is typically a benzodiazepine, and for our refractory therapy. Looking further into our urgent therapy selections, you see that there's a large number of patients receiving levetiracetam. This is expected due to the availability of levetiracetam in the emergency department as well as levetiracetam being considered to be relatively benign. I mention this because in our order set implementation, we focused a great deal on moving towards a weight-based dose of levetiracetam. For our secondary outcomes, the current only statistically significant difference between the two groups is our continuous EEG utilization. Of note, in the pre-protocol group, we weren't able to use continuous EEGs at all due to lack of resources. However, we have recently hired a new epileptologist that has been working towards increasing our ability to use continuous EEG monitoring. I also want to mention our intubation rate of around 50% and our time on the ventilator of around a day and a half for both groups. I mention these because to me, this is what helps come to the conclusion that we have a key area for improvement as I've identified as being our initial management of these patients. And that's because if you think about our intubation rate of around 50% and compare that to the literature, which reports around 30%, we have a much higher intubation rate, and I think this is due to our inadequate initial management. I also think that there needs to be more post-protocol data collected prior to evaluating the true effectiveness of implementing this order set. We also need to take a look at how often the order set is being used in these patients. Additional EEG monitoring is also needed for patients with continuous infusion AEDs, and that's something that we're currently working with neurology on to increase our resources. So our self-assessment question, which of the following is an effective strategy to improve adherence to evidence-based AED selection and dosing for treatment of status epilepticus? And the answer is C, implementation of a standardized protocol along with provider education. These are my acknowledgments, and I've listed my email below for your reference, so feel free to contact me with any questions you have. Thanks.